what I'm going to be talking today with you is about suicide prevention. And so this is a little bit of a heavy topic, and I will intermittently stop and ask for questions. But basically, it's a very tragic problem, the suicide, but it can also be preventable. So what I'm going to teach you is basically some identifying factors, but I don't want you in any way to put pressure on yourself that you should have known or you could have known or something like that. What I want to do is just teach you some signs and kind of teach you to listen to your gut and teach you to call EAP if you do have a concern. So, and some facts about suicide. Suicide can be very scary, so I just want to explain some facts about it and let you get more comfortable with trusting yourself, trusting what's going on, and feeling more comfortable if you're not already with calling EAP and asking for guidance. You can always do that. And then I'm going to define some terms that we might use that might get confusing as well. So this is not going to turn you into a diagnostician, so I'm not going to try to make you a mental health provider. But again, just some ideas of what you can do to support. So we're going to review some statistics, risk factors and warning signs, and then what you can do. So every 14 minutes, another life is lost to suicide. Suicide took the lives of over 38,000 Americans in 2010, and there were almost 1 million attempts to take their lives, for people to take their own lives. And it's about 12.4 people per 100,000 in the general population, but the highest rate is among those that are 45 to 54, which is kind of important because those are the people in our workforce. Additionally, suicide rates are the highest among those that are divorced, separated, or widowed, and lowest among the married. And we'll talk more about that. So every day, about 100 Americans take their own lives, and over 2,800 visit the emergency department for self-inflicted injuries. When you're looking at kids, 15 to 24, they've continually risen over the years in their suicide rate. And in 2010, youth were 14.1% of the population, and they comprised 12% of the suicides. More teenagers and young adults die from suicide than from cancer, heart disease, AIDS, birth defects, stroke, pneumonia, and influenza, and chronic lung disease combined. So this is a very high, obviously, as you can see, it's the 10th leading cause of death. So it's really a problem, and it's something to take very seriously. And I'm going to go back to young people because many of you probably have teenagers or young people in your life. So when they did surveys of high school adolescents, they showed that there is a statistically significant increase in the risk of suicidal ideation and behavior among students, especially males who identify themselves as gay, lesbian, or bisexual. But there's no yet empirical data on this population for completed suicide. Suicidal behaviors in young people are usually the result of a process that involves multiple social, economic, familial, and individual risk factors, which we're going to talk about, and mental health problems. So it's all of it together. If, you know, people are pretty resilient, so they could go through one of those or a couple of those and be fine. Not everybody's suicidal. But when you put all those together, it can sometimes basically be overwhelming for someone. Identified risk factors for suicide and attempted suicide for young people are mood disorders, substance abuse disorders, certain personality disorders, low socioeconomic status, child maltreatment, parental separation, access to firearms, interpersonal conflicts, or losses. And really, bad things happening to someone can be a factor. It just depends on where that person is when that bad thing happens and how they are in their mental health as to whether they consider suicide. So let's do a little more statistics. So firearms account for 50% of suicides. Basically, they're accessible, it's fast, and so they account for half of the suicides. Males are 4 times more likely to die from a suicide. That just means they're more successful at their suicide attempts than females. men are almost, sorry, like I said, they're 4 times. But women attempt suicide 3 times more frequently than men. But the means are less lethal. Usually it's something maybe like an overdose or hurting themselves. But there has been an increase in women getting more lethal. And the most common way for females is poisoning. And then there are actually higher suicide rates in certain cultures, such as Native American and Caucasian, than other cultures. And it's surprising, most people don't realize this, but older Americans, meaning 65 and older, they're only 13% of the population. They suffer 14.9% of all suicide deaths. So we don't usually think of our 65 and older population as being higher risk, but they actually are. So I don't want anybody to be dismissed because of their age, whether they're very young or older. So a good way to look at suicide is that people really see it as a way out. They don't know any other way, and this is a way to release that pain. Not all people who commit suicide have premeditated suicide. For some, it's a very impulsive act, and it can be fueled a lot by alcohol and drugs or a loss in a relationship. Most people that have attempted suicide will feel suicidal again. It's kind of once they've broken that barrier, they will go back, and it'll be an option again in the future. Not that they will try it again, but it's always an option. And so a lot of times you need very long-term treatment for people with a serious mental health issue to prevent that suicidal ideation if it is an option for them. So let's look at some factors. So there's life events, which we touched on a little bit, and then there's individual risk factors. So let's look at life events, and we talked about this just a tiny bit. These are significant occurrences, as you can see, that happen. A lot of people would think, why retirement? Well, maybe the person doesn't feel like they have a purpose in life anymore. You know, a lot of people identify themselves by their job and their role, and they worked very hard and have a lifelong career, and maybe they've gotten a lot of accolades and recognition, and now they don't have an identity. And so that can be very disheartening for someone and very disturbing, and they may just not enjoy retirement. You see that all the time. You see people going back to work after retirement because it's part of their identity. Obviously, negative things, divorce, death in the family, chronic, some of these are, you know, if you have a chronic medical problem, it might be you in your mind would think, oh, well, I could see how somebody might contemplate that. But even problems at work. So it may be something that you or I would do fine with, not that we would enjoy a divorce or difficulties with coworkers, but we've got to understand other factors are playing into that, so that might be an instigating factor. A lot of times, suicide will happen more often when there's economic hardship, and the unemployed are at higher risk than those with any type of job. So financial trouble impacts family relationships, as well as it just adds additional stress to an already stressful situation. So these are some individual, these can be specific to one person. Sometimes suicide is associated with fantasies of escape or reward or reunion. It can basically be a large or an excessive reaction arising from intense preoccupation with disappointment or humiliation. But really, as I said earlier, in order to understand it, it may not be as much about death and wanting to die as much as relief from pain or a solution to a problem. And it's a very permanent solution, obviously, and but that might be what they feel like is the only way out or the only solution. When you're suicidal, you're in a very desperate place. So you're not always able to see other options, and everything seems like it's a catastrophe at that point when you're there. So it might be obvious to us. Well, there's so many other options. You could do this and this, but that person may not be in a place to even see that. It's very complex. It usually includes hopelessness, anger, revenge, or a final cry for help. It could be a form of seeking punishment arising from guilt or shame, or it could be a way of avoiding punishment. It may be manipulative, or it can be psychotic. Somebody can hear voices or see things and think that they're telling them to kill themselves. But the most common feature is probably utter and complete hopelessness and helplessness. When hope dies, every experience becomes very negative. They come to expect the worst, and guilt and shame and despair increase. They can't see anything positive because that would imply hope, and hope that things would feel better. And now hopelessness does occur with a lot of mental disorders. More than 90% of people who kill themselves have depression or another diagnosable mental or substance abuse disorder. And those with a family history of mental disorders or substance abuse problems are at increased risk, as well if there is a family history of violence or suicide. If there's firearms in the home, then the means are more available. And certainly if an individual has had a prior suicide attempt, like we talked about, there's an increased risk for future attempts. So basically in mental health world, what we look for is an intent. That means they want to do it. And access. That means they have the means to do it, whether it's drugs, alcohol, a weapon, and a plan. And they have drawn out a plan. So those are your highest risk of suicidal, what we call suicidal ideation or suicidal thoughts and risk. So there's also, though, when somebody is at that low point, there can be an alteration, or there's research at least indicating that there's alterations in the chemicals in the brain called neurotransmitters. And one specific one that you probably heard about is serotonin, and that's associated with the increased risk for suicide. Serotonin is not only used with mood regulation, but also in control of impulsive behaviors. And suicide can be very, very impulsive. So I just want you, if you take away something from this, just know that suicide is, in my experience, is very an active impulse. And so just remember that. And so when that serotonin's low and you have a lack of impulse and you have substance abuse going on or drugs or alcohol, something that's lowering your inhibitions, that impulse risk increases. So sometimes when people have a deficiency with that chemical, they're going to be at a greater risk. Risk can also be high in early stages of treatment. Sometimes when people are depressed and they start to feel better, they just start to feel better just enough to complete suicide. Among men hospitalized for alcoholism, the risk for suicide during the first 5 years after treatment is 75 times greater than the general population. Alcoholics often have other risks, including major depression, poor social support, such as an alienated family, serious medical illness, or unemployment. And people who abuse several substances are at a greater risk. Abusing alcohol or other mood-altering drugs like we talked about will lower those inhibitions. Many people who commit suicide are physically ill, or they believe they are. More than 80% have seen a physician about a medical complaint within the last 6 months preceding the suicide. So when you think about that, then thinking about the suicide rate among people with HIV infection or AIDS, that's said to be 30 to 60 times higher than the general population. People undergoing kidney dialysis, it's up to 400 times higher. And older adults are undertreated for depression. Their suicide rate is more than 50% higher than the general population. And only 10% of elderly get treated for depression. I think they're often overlooked. Men at over 80 are particularly at risk. And it's a common companion, depression is a common companion to illnesses that occur in older people. So basically when people feel like, if they have a terminal illness, if they feel like it's never going to get better. So there's this common theme, which is, I'm going to go back to hopelessness and helplessness. I hope I'm not breaking this down too much, but I hope you see the theme going on. And then finally, people that have been exposed to suicide, including family members, peers, or even lots of reports are desensitized to seeing it in the media. let's say part of the job entails dealing with a lot of suicide or aftermath of the suicide or something to that nature, which I don't know that any of you would have that kind of role, but that alone can present suicide as being an option. It opens that door as an option, and once that door is open, then your risk is much higher. It doesn't mean that everybody who's exposed to it will commit suicide. It just means that now it's kind of, you've opened that door to it being an option. Okay. So since most people that commit suicide are depressed, let's look at some of those. Are there any questions so far? Okay, and I'll take questions at the end too. So some of you probably know these. These are very classic symptoms of depressed, and this person that has all these features will look depressed. You've seen this person before. If they are, a lot of people realize sleeping too much might be a sign of depression, but they don't realize not sleeping is a sign of depression. Changing their, you might see weight loss because people have difficulty. They either eat too much, or you might see a weight gain. They eat too much, or they don't eat at all. Their movement timing is different. Slowness would be expected, but they might have unusual speed, so there might be a mood disorder going on there as well. They don't take pleasure in your typical activity. So maybe something they used to enjoy, maybe part of their job they really would always volunteer for, and they really enjoy doing that part, and now they just really don't have an interest anymore. They're not as engaging in staff meetings. They're withdrawn. They don't eat lunch with people anymore. They're just kind of isolating. They often are tired. They might look tired because they're not sleeping. They might not be able to focus. They might have more difficulty getting tasks done at work because they just can't concentrate. Or they might become more, they can't make a decision as quickly. They're not as decisive as they used to be. Some of this, you may not see the feelings of worthlessness or guilt, but it might come out. Oh, well, nobody would want to come over anyway if I had a party, or nobody wants to have lunch with me, something like that. Or I know I shouldn't have done that. I'm sorry. Apologizing for things they're not really, so they didn't do wrong. They're just feeling guilty. And then they just express sadness. They're tearful. They just look sad. So somebody could just be sad, but this is kind of a chronic depression. So let's take out, some people are just sad because life happens and things happen. They lost a pet. They lost a family member. They're going through a divorce. They may not be suicidal, so I don't want us to say depression equals suicide, but most of the time people that are suicidal are depressed. And remember that depressed mood may be temporary or it can be long-lasting. And while anyone may have the blues, clinical depression is a serious illness. This is a long-term issue. This is where, in therapy world, we call it where it gets in the way of your functioning. So somebody just being down one day, I don't want you to stress out about that. I mean, obviously, if you feel comfortable reaching out, hey, how are you doing? Being a friend, being a good coworker, I get that, and that's great. But but just understand that they may just be down, and then they're fine. But if somebody has this long term for weeks, then they're going to need some medical or a mental health professional to help, some professional attention. And those are very treatable, these depression and any mood disorder. So that's a good time to call EAP or refer the person to EAP. So when people have depression, they often really think in black and white. Decision-making and problem-solving skills may be impacted. They can make poor life choices. When they have depression, worry can become overwhelming. I call it catastrophizing. Everything is a disaster, and it can start out small, and then it just builds and builds and builds in their mind, and you may be thinking, wow, it was just I don't know, you just hurt your finger. You're not going to, but they may take it to, I'm going to get an infection, then I'm going to go to the hospital, and then they're going to have to cut my finger off. So it could be very, that's what we call catastrophizing, kind of going down that spiral. sometimes you will see some anxiety going on with this. That's if they said the finger and then I'm going to have to go to the hospital, that's anxiety as well. They're really nervous. They're anxious about what might happen. And sometimes people might try to relieve this by using the wrong stress relievers like alcohol, drugs, gambling, overeating, internet, even compulsive sex. And this could be something that they just aren't, it's going to create more anxiety, more depression. It's going to be a bad cycle for them. But they really believe things are never going to be happy, again, never going to go right, and they can't make objective decisions. I know in my personal life, as a therapist, I can see somebody who's depressed and understand where they're coming from. But I know, and I don't know if this will help, but in my personal life, it feels like the person is very self-absorbed because they can't get out of that. They're in this cycle, and it's all about them and what's going to happen because they're so anxious they can't see the forest for the trees. And so that's so I don't know if that helps you guys, but that's kind of how I know in my personal life because I don't always have my therapy hat on. So when I meet somebody, I'm not expecting to have to, I don't diagnose people in my personal life. And it's not until I'm thinking, oh, gosh, they seem, very focused on themselves and everything about them. And I don't mean selfish. I mean, they can't snap out of that and see what other people might be feeling. That's sometimes a feature of depression, too. Okay. So like I said, most depressed people do not commit suicide. There's a lot of depressed people that get treatment, get help, they're on medication maybe, they heal in their own way, and they deal with this every day and they cope. But most people who attempt or complete a suicide are depressed. So if you do notice somebody's depressed, I don't want us to jump to them being suicidal and you to stress out on that. But obviously, getting them in touch with EAP or counseling, letting them know their benefits is definitely helpful. Okay. So what you want to notice for suicide warning signs is behaviors that kind of increase or change from what that person's norm is. So I have escalating anger, agitation. If you have somebody who's always angry and always agitated, that doesn't necessarily mean they're suicidal. But if you have a normally even-keeled person and all of a sudden they're anxious and angry and agitated and they're having a change in their weight and their appearance, they're looking more disheveled, they just don't care as much and they're not sleeping and they can't concentrate and they're just feeling down and they're really nervous and impulsive, this is all just not them, then there's a concern. And again, I'm not asking you to diagnose them, but these are just some things to look at. So obviously one of the most apparent signals of possible suicidality, besides them saying, I'm feeling suicidal, is an increase in moodiness or seeming really just down and sad. Persistent boredom can also be a precursor to indicate that that person's life is not fulfilling. And when people don't have interest or purpose, depression can set in. They don't have anything they enjoy anymore, like we talked about. When they have difficulty concentrating, they may start to feel overwhelmed. And combined with other things, they just might feel life's not worth living. It's too much work. It's too hard, something like that. If they're having a period of despondency and they suddenly become cheerful or very calm, and there's been no significant change, this could be a sign that they don't care. And so if you have somebody who's totally depressed and they're not engaged in anything, and all of a sudden they're cleaning everything up and they're happy and they're cheerful and calm, that could be a real warning sign that this person has made a decision that they're going to do this. And so that's something to be aware of. Don't assume that if they're cheerful that, oh, they just snapped out of it. Great, they're better. And we'll talk about what to do. So like I said, they might have chosen to execute a plan. So obviously verbal. I don't want to turn you into a counselor. You see some risk factors. and some behaviors to look out for. But I do want you to be aware of some things that people might say. And there might be a time, especially as a manager, that you're going to have a conversation. You may have already had these conversations. You may have called me and we had these conversations together. But I don't mean you, but I mean about your employee. And so that's fine. So, but you are going to have some, you may be, not have to, you may be thrust into the middle of this conversation. So I just want you to know how to respond and what to look for without feeling like you're being their counselor. So what they may do, some specific things people might say, first of all, is a threat. I don't want to live anymore, or watch out because I'm just not coming back and forget it, it's all over. I'll just take care of this myself. The end is near. You know, things like that, or I'm going to kill myself. You know, statements just very clear or just very final. If they talk about it's no use, nothing matters anymore, soon you're not going to have to worry about it, or worry about me, I just can't take it anymore. These are those discouraging and hopeless statements. Another one could be if somebody comes across preoccupied with death. You see this a lot with teenagers that are suicidal, but adults will do it too. But drawing death, going on websites about death, different ways to die, something like that, or even in letters or poems, it may be a sign. Now, it doesn't necessarily mean that they're suicidal, but if they're depressed, they're not interested, they're seeming hopeless, and then they're drawing pictures about death, that would be a high risk. So these are all kind of warnings. Physical symptoms, complaints about physical symptoms can sometimes be a signal, especially if it's a terminal illness like HIV, AIDS, or cancer, or if they have a chronic debilitating disease like heart disease, kidney disease, even arthritis. And the complaints in and of themselves don't mean somebody's going to commit suicide. It just means that we need to take a closer look at them. And if they have all these symptoms, we need to have a conversation. Also, sometimes people will give you ambiguous or indirect indicators or goodbyes. They might say an unusual, I'm going to go away on a really long trip, or you won't have to worry about me anymore. I want to go to sleep and never wake up. I'm a burden. I can't see how it will ever be better. Those are, I wish something would just happen to me. Those are also indicators that they're thinking about suicide. So, what are some red flags? So look for a means. Do they actually have a way to do this? Now, that being said, a bottle of Tylenol is can be someone's most effective way to complete suicide. So it doesn't have to be that they have a gun, but do they have a means? Have they talked about or written about or told someone else about wanting to die? Do they have a plan? This is very important. Have they purchased a gun recently? Have they talked about having knives? Have they talked about just taking, overdosing on their medication? Have they given everything away? Are they putting things in order? Are they getting their will organized? Are they ending relationships? And of course, if they're threatening, they're stating intentions to harm themselves, and they're withdrawing from people and not doing things, not getting as involved. So these are huge red flags. And the inhibitions, let me see if what I want to mention too is alcohol and drugs. If there's an increase in alcohol and drugs, again, that lowers your inhibitions. And so it's really, and we can't, our thinking's impaired, so we don't make the best decisions. And so if they're thinking about suicide, that drugs and alcohol, we always as clinicians here have to ask about drugs and alcohol when we're assessing someone for suicide, because the risk is so high because it's such a pathway to impulsivity. So they're going to be, you're using the drugs and alcohol, you're much more impulsive, you might follow through with what you've been thinking about for months. Okay. So this is some reasons that people might not seek help, and there can be cultural reasons, social reasons, or even economic. And hopefully with EAP, we've taken away that economic reason for at least the 6 sessions that you guys do get. But some people just feel like there's a stigma. They feel like, I have a terminal illness. I'm not crazy. Why prolong the inevitable? They might have that kind of thought. Or they might think they're weak. You know, they might feel like that's the best way and to go out and not to get help and have to talk it out. And what's talking going to do? They might feel they might lose credibility. They might not want to open up to people for people to think they're crazy. And they may not want their personal problems exposed to other people. Some people just think that nothing's going to help. They're so hopeless that why would I even try? Why take the energy? They might not even have the energy when you're that depressed. It's hard to get out of bed. But to go and get help might be overwhelming. Others simply don't even know it's available. It's not even in their purview. They have you know, like I said, there's that, you get in that kind of rut where you can't see other options, and this is and the suicide's the only way out. They might not even think about getting help or know it's there. And then sometimes a lot of people, and you probably know many of them, are helpers, and they are fantastic helpers, but they always help themselves last. If you're a mom, you probably know what I'm talking about. So, and not that moms are depressed and suicidal, I'm just saying that, you know, we are trained, women are particularly socialized to be nurturing to others, and then you put yourself last. And I think men are too, I think in different ways. So they might be, law enforcement people might be trained to just take care of everybody else. You know, it's just a very caretaking type career actually, and put themselves last. Or there's all kinds of careers that many of you have that would encourage that. So, and there might be some trauma or family secrets that they don't want to share, and they don't want to talk about, or they don't want to rehash. So that might be another barrier to seeking help. So what can you do? So it's a myth that people who talk about it don't do it. That's kind of what you said. Well, if they were really going to do it, they wouldn't have said anything. I hear that all the time. I hear it from other people that are in training to be clinicians, so we have to clarify that. Take it seriously. We never mess around with that. If they're talking about it, there's a thought there, and it takes an impulse. So that's all we need. So take it very seriously. Be willing to give and get help sooner rather than later. And I don't want you to think that the person, it's a myth that people who try to kill themselves have got to be crazy. Most people suffer from a recognized mental disorder, but it's depression. It's depression. It's something that any one of us could have. And it's something that gets in a place that without help changes the chemistry in your brain. So, yeah, it's called a mental disorder, but it's something that life can really provoke. You know, you have enough stuff in life, and I'm sure you've all been through it, where you have enough events happen, and you just can't feel good in that moment. You can't be happy at that moment. It's just a really dark period, and that's normal. So they're not crazy. They're going through a very, very difficult time. And they're not necessarily delusional or psychotic. And usually they can manage their daily affairs, so they're pretty high functioning. Also, sometimes I will hear people say, you know, those problems weren't enough to commit suicide over. But we can't assume that because we don't feel like it's a big enough problem that the other person feels the same way. So again, it's almost like maybe it was the last straw. Maybe it was the final thing that happened that they just couldn't add on to their big plate of negative things that had occurred. So that's why giving that help sooner than later is so helpful. And it's not a last-minute activity. All the textbooks on depression say it should be treated as soon as possible. But that's hard when your suicidal person is afraid that getting help may bring them more pain, such as being told they're stupid or crazy or sinful or manipulative. And they may be, if it's an employee, they may even fear being suspended from their job or that their personnel file will contain information about their treatment, which is, you know, and a valid fear, and they need to be reassured about that. It would be understandable if an employee would think that. They just need to be reassured about that. And listening, give them every opportunity to unburden themselves and show that you take their feelings seriously. And this is when you can listen. again, I don't want you to be their therapist. I don't want you to feel like you have to meet with them weekly for an hour to check in with them on their feelings. But if they indicate, if they're in the moment and telling you about what's going on with them, that's a great time to get in there and say, did you know we have this wonderful benefit of EAP? And they have counselors that know how to respond to you, and I think this would be the best thing for you. And you only have to say, I'm not a counselor, but just say, I think this could really benefit you. Let's call together, you know, that kind of thing. So, and compassion, just listening and letting somebody know you heard them can make a huge difference. You could save somebody's life that way. So again, I'm not trying to, some of you may be feeling like I'm putting you in a therapist role, and I'm really not, but just engage, just listening and letting them know you understand, you hear that they're having a hard time, and you're glad they felt comfortable enough talking about it, and now let's get them some help, that kind of thing. And engage with them. If you have somebody who's withdrawn, you have all these signs and symptoms, you know, talk to them. Ask them, how are you doing? Engage with them. And then, like I said, direct that conversation to getting them assistance. If they mention, well, okay, sorry. Let's go to the next one. So when do you refer? So obviously sooner is better than later. So if you notice somebody's depressed, and they're just not functioning on the same level they were at work, they're withdrawing, they're not engaging like they used to, any of those symptoms, it doesn't have to necessarily mean they're suicidal, but if you notice there's a change, it's not them, then maybe you let them know about EAP. They may not even realize they have it, or they may think it's only, a lot of people think EAP is only for issues like alcohol. They don't understand that it's also just coaching, or just balancing work and life, or they've had a lot of changes in their life, and just having a counselor go, it's completely confidential. Sometimes I refer to it as coaching, so people are more open to it rather than, you know, sitting in an office with a shrink, I guess is what a lot of people think. Now, so sooner is better than later. However, it's never too late. So you get a gut feeling something's really bad, go ahead and give us a call, talk to them, talk to the employee. But remember that safety is your primary concern. It's natural to feel conscious and concerned about the impact of a referral on the employee's career. However, you've got to weigh what would happen if I didn't intervene and something did happen. If your gut is concerned about their safety, then that's a good sign that you need to intervene. If you couldn't sleep that night because you're worried they're going to do something, then you need to call and get some help. And we'll talk about different levels of intervention. And then, of course, if you're not sure, please call us. Please call EAP. We're available 24/7. We're all trained in crisis intervention and talking to people who are suicidal. We've all had that experience and getting that person assessed. And so if you have, and what I mean is you can call us and ask us. You don't have to necessarily put the employee on the phone at that moment. You can say, listen, this employee is displaying blah, 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 and I'm really, really concerned about this. Can you just help me? What do you think? And get our, you know, and we'll help you. That's fine. We're glad to help. So a lot of people, when you're helping, always just ask the question, ask directly. A lot of people think they're going to plant oh, they're so depressed. If I say anything, that'll just open that door, and maybe they'll commit suicide. No. If that person, if you ask them about suicide and they start talking about suicide, they've been thinking about it for a while. You did not plant any ideas in their brain. So ask them, are you having thoughts of suicide? Are you feeling like you can keep yourself safe? You know, if they've said something, ask them, well, what do you mean by that? You say the end is near. What do you mean? Do you have a plan? Do you have a way you do this? You know, that kind of thing. Again, I don't want you to be a therapist, but it might be an emergency situation. You might not have time to call EAP. You know, but a lot of times when I talk to a manager, we'll ask, well, And a lot of times managers will have asked that question, you know, well, what do you mean by that? And just clarify, because sometimes people make really, like we talked about, ambiguous statements, and you don't know what it means. And you as the manager go home, you're stressed out about it, you can't sleep. And then had we been able to discuss it, I would have just said, let's talk to them before the end of the day, see where they're at. Because it might just be somebody's really just had a hard day and they just made this off-the-cuff comment, but we don't want to take it as that. We want to just clarify and let them, you know. So let's ask them directly. Get the specifics of what they meant by that. If they have a, well, how would you do that? Or have you thought about how you do that? If they're actually suicidal and you've asked directly and you've gotten specifics and they have a plan, well, yeah, tonight I'm going to go home and I'm going to shoot myself in the head because that's just the only way out. And I've got my gun, it's loaded, it's ready to go, I've signed my will, we're done. Then you need to make sure that person's not alone and get them to the hospital. And we're going to talk more about that, but I just want to go ahead and put that out there. That's the extreme scenario. Or you can call 911 and whatever is more comfortable for you, getting 911 to transport, because 911 usually can admit people to the hospital, or getting somebody to transport them, depending on the situation, but whatever is the safest. Also, no secrets. A lot of times people will say, please don't tell anyone, but I'm feeling like I want to hurt myself or I want to kill myself. It's great that they have chosen to share that and get that out, because now you can help them or they want help to stay alive. But it's real important they know that this is not something that you keep secret, that your concern about them first is that they're safe. And so we don't, you know, we can't keep that kind of secret as much as you understand that you're going to treat it with as much respect as you possibly can and not talk about it with other employees, but you're only going to share what you need to share to get them the help they need to keep them safe. And then they can share whatever they want in the future. But at this point, you can't guarantee a secret, especially if they need emergency help. So at this, and you also are going to need persistence and patience. That might be needed in order to let the person know you care. And be kind and calm and honest about your intentions to get help. Otherwise, they're not going to trust you. So you can be straight and upfront. You could say, I don't want to lie to you. I'm just going to be very honest with you, that because I'm concerned about what you told me, and I'm going to have to do everything I can to keep you safe because that's my #1 priority. And I understand that you may be very angry with me, and that is okay. But if it keeps you alive, then I'm okay with that. And you might have to get a little firm, but you're going to be patient, you're going to be calm, and you're going to get them the help they need. So, emergency help. So this is when the person's safety is in imminent danger. They're in immediate danger. They said, yes, like we just talked about, I'm going to do this. I have a plan. I'm going home right now. I'm going wherever. I'm going to go to the park, wherever. I'm leaving, walking out. Then you call 911. You make sure they're not alone. I don't know if you know what a mobile crisis unit is. A lot of you, if you Google your county and put mobile crisis, you should be able to find what it is, or at least a local agency that will be able to direct you to that. But if you don't have that number readily available, which is very understandable, I would just call 911, and they'll be able to help you and direct you. Don't leave them alone until the professional arrives. And then any weapons or drugs or other items that can inflict. It says remove. I'm not asking you if they have a weapon, please don't go and remove their weapon. I don't mean that. I mean in whatever the safest way possible. They have a weapon. If they're in their car and they're driving home, you had to call the police, notify the police or whatever. But please be very cautious and safe when you're dealing with this. So I don't want you to, I'm not asking you in any way to get in harm's way yourself. I'm just asking you to do, in that situation, at least this, I want to give you a plan so you know what to do. So it's helpful to know the signs and symptoms of depression and risk factors for suicide. And you can You can always give support. But really, most importantly, if you do have an indication, please call EAP. You have us at your availability. And if you're just not sure, or if you are sure, because then what we can do is we can also do an assessment with the employee over the phone. And then manage your own stress. This is very stressful. Some of you probably have employees that talk about suicide quite frequently, and they may not even be suicidal. It may even be something that they just say, and I'm not dismissing it, but you still have to take it seriously. But you hear that a couple times, and one time is exhausting. Hearing it repeatedly can be very, very stressful. So please call, take care of yourself. If you want EAP for yourself, it's like I said, it's completely confidential. These are the same therapists that are on your insurance panel. And then do some health care and keep yourself physically and psychologically healthy. So this can cause, when somebody talks to you about suicide, it causes a lot of anxiety. You'll notice your heart racing. You know, it's scary. It can be. And so, and you're very calm and you're on. And it's also exhausting after you're finished because it could be a very long conversation. And so, take care of yourself and do some self-care as far as like what are things you like to do, what are things that relax you, talk to somebody, call EAP just for support, talk to your, you know, if you have your own therapist, and without taking, you know, breaking confidentiality of your employee or whatever, but reach out for support from others, go to dinner, have a, you know, do something that you enjoy. So when you do, if you have an employee who you call for and they have expressed suicidal thoughts and you're really concerned about them and you put them on the phone with us, I want to let you know what the process is, because I think there's some confusion sometimes about our verbiage, and we are so used to saying it, I think, that we don't really clarify enough. So I want to clarify that with you. So we're all, like I said, trained to do immediate crisis assessments. And so in a routine situation, let's say somebody just calls and says, I want to see a counselor, I had a bad day, okay, or I am just having a hard time, I want to see a counselor. Routinely, what we'll do is get them an appointment within 3 business days. And that's our goal. Unless the client themselves, or I say client, employee wants something that fits specifically at a specific day and a specific time. So they might not get one for 2 weeks because it was that time that they wanted. So we try to cater to the employee as best that we can, but we'd like to at least have one option of an appointment within 3 days. But we won't make somebody go to that. We'll just offer it. Now, if it's urgent, what we've done, and this is a determination, the clinician or the counselor who's answered has talked to the employee, and they've assessed them and found them not to be an emergency, which I'm going to go into, but they found them that they could wait for an appointment either that day or within 24 hours. They're not an immediate, they're going to go out right now and hurt themselves risk, basically. That's basically the gist of it. And the employee has also agreed to what we call a safety plan. They've agreed not to hurt themselves until they can go and talk to somebody, a professional. And they've reassured, and the counselor on the phone really feels like they'll follow through with that. They've given enough assurances, and there's all these different questions, and there's this algorithm that we have, and there's all these different ways we ask, and so it's a very thorough assessment of talking to them and determining the risk level. And there's things that it's not just what they say, it's how they say it and how they phrase certain things and that kind of thing. So we're really assessing on many different levels of the risk involved. That doesn't mean we're perfect. It doesn't mean that we're mind readers. But for the most part, this person's indicated on some level that they're safe to wait for an appointment. However, we don't want to make them wait 3 days because we're not quite sure that that's safe. But maybe 24 hours, they'd be safe to go to the appointment from work or go to the appointment after work the next morning, that kind of thing. So that's what we call urgent. So if you ever hear, if you're a manager and you call us in and we say we found an urgent, or we're going to have to look for an urgent appointment, that means within 24 hours. In our world, that doesn't mean emergency. Emergency means you put them on the phone with us, we talk to them, we've determined that there's such a high level of risk we can't send them out anywhere to be alone, and we want them to go straight to the ER to get assessed by a professional. And so that would be an emergency, that they're immediately at risk right at this moment. And so we'll do what we can to facilitate them getting transported there, them calling their emergency contact or whatever, and confirm that they've made it to the ER, all that kind of thing. So because they're at immediate risk, they can't agree to a safety plan. So they've indicated they have maybe intent or means or access, or there's some sort of maybe substance abuse or something that's just going to increase that risk, and they can't guarantee their safety on any level, or they don't feel like they can keep themselves safe. Then we'll do what we call emergency and get them to the ER. And that's beyond EAP because that's the medical thing, but anyway, that will facilitate getting them there. So those are 3 terms that you might hear, and I want to clarify that with you. So how do you use the EAP? You call us, our number, 1-800-869-0276, or you can go online. If you're calling about a suicidal, you can always go, I'm sorry, I didn't insert the password. Sorry. It's interior EAP is your password. It's all lowercase. Well, it doesn't matter, but it's interior EAP. But if you feel like somebody's at risk and they're suicidal, please don't go through online. Please call us. Because, you know, there's a little bit, you know, a call you get an immediate, but online we're pretty quick, but we may not be that quick, so it's better for us to have a conversation. And then there's some additional information that you can give people, or if you want to follow up on this. So basically the takeaway is if you feel like somebody is suicidal, don't be afraid to ask the question, what do you mean by that? If you feel like they are vague or they have to get help or they're going to be mad at you, I don't want you to be afraid of that. I don't want you to be afraid of suicide. I know that's kind of a lot to ask. But know that you have resources, and if you have questions, and I also don't want you to feel like you're a therapist, but feel free to open that conversation, you know, or let us know, and so you have some concerns. Now, when the employee calls, it's completely confidential. We cannot tell you what they said if they don't give us permission. But you will know if it's an emergency, we'll have to say, okay, I need to tell somebody to get you to the ER right now. I need to confirm. I'm going to have to tell your manager. I'm going to have to tell your supervisor, whatever. So we'll have to do something. If it's safety concerns, we'll have to break confidentiality to ensure their safety. But it may not be with you, maybe with their emergency contact or whatever. But so unless they give us permission, but at least you have us as a resource. But again, I think most people just get real nervous about asking generally, like, well, what do you mean by that? And they don't want to tread too far into it or anything like that. So being direct and listening and being compassionate are really great responses if you have concerns about that. So I have a couple questions, and I'm sorry, I totally got into this and I did not see the questions on the side. What are aggressive tendencies? Like I said, if this is something that is unusual for the person, maybe what I'm describing is more agitated. And maybe they're more physical because they're agitated and it's sudden and it's just a lot of times when you're anxious or feeling bad, you're going to kind of like we tell people about kids, when you feel bad, you act bad. And so I think I'm sorry, the computer just went blank. Anna, sorry, I'm trying to. But they might be more aggressive by you know, being more physical, being more in your face, but I don't mean like a bully. I mean, they could be, but just look at if it's something different. I know that's a very vague answer to your question, and I apologize, but everybody's so different that I can't give I see it as agitated and gruff and not patient anymore. They used to be patient, that kind of thing. And the other question was who's covered by EAP? And that is so full-time, part-time, and seasonal within the season employees are covered, as well as their family members, children living in the home up to age 21, and then I believe if they're in school up to age 26. And it's and also domestic partners. So children, spouses, domestic partners. So my computer, I'm sorry for the technical challenges. Anyway, does anybody have any other questions they want to ask verbally right now? Or Joy, if you can read the questions that I haven't answered, you can read them off to me.
Can you show the telephone number again?
Sure, I can tell it to you. It's 1-800-869-0276. And what I'll do is I will send either Donna or Joy the handouts for this PowerPoint so you can have them too. So she can email them out.
Heather, this is Joy. You've answered the questions that are here on
okay.
on the WebEx website.
Okay. Okay, somebody asked a really good question. If you, she said, or he, you showed a list of symptoms. What if we only see some of these symptoms, i.e., when does one need to worry? I think as a supervisor, you do walk a line of, do you pry into their business or not? And I don't want you to pry if you know, but if you notice that there's a difference in their functioning and a difference in their workload or their work performance, I guess, not workload, work performance, and they're just not, they just seem down, I think at any point for that, you can at least informally, which meaning you just go up to them and say, you know, I noticed you've been a little different. Are you okay? And they might, you know, respond or not and say, you know, you seem stressed or you just seem different, or have a conversation with them of, you know, I really noticed that there's been a change in your work and I want to make sure you're okay. You know, or something like that, where it's you, it's sensitive, it's not, you know, rude or anything. But, and then just let them know that there's EAP. And that way, at least you've given them that offer and they might seek help on their own. And you can tell them a little bit about what EAP is. I would start to worry if those red flags start to come up, you know, or if they're just drastically different than they were before. I'd start to worry. And you can always call us and consult. You can say, Heather, I just need to talk to you because I don't even know if I'm supposed to worry about this person or not. Because like I said, they could just have the blues. They could have just lost a pet and just are really having a hard time because they had the pet for years and years and years. And they might just be too embarrassed to say that to their boss, that, yeah, they're really blue because they had a pet, because what's my boss going to think? I mean, most people, you know, that kind of thing. So that would be, they might not want to open up. So, but just informally offering might be some way, or you can say, you know, you just seem down. If you want to talk about it, feel free, or something like that, whatever you're comfortable with. So another question is, do I have any suggestions for trying to get someone to go to the doctor? Does it help to offer to go with them, make an appointment for them? Okay. I think if you're a supervisor and you have an employee, I would not go to the doctor with them. I think you're, or at least I would consult with HR before you do that, because I feel like that might be getting you in a situation where you might be crossing a line that you may not realize you're crossing. And so I would, that's private information, and we can't make anybody go to the doctor, frankly, but you can have conversations with them about your concerns, and you can kind of paint the picture for them. I have talked to supervisors about how somebody's seemingly they need to go to the doctor. There's seeming a medical problem that's inflicting on their work. And as a colleague, you share with them, you know, I'm really concerned because you used to perform, or your normal performance level is right here. You're so good at this and this and this. And I've noticed that you haven't been able to concentrate as much anymore, and you're not doing the things you enjoy as much anymore, or it's not the same level that it was. And you say, are you okay? Everything's fine. Everything's fine. You seem like you're not feeling well. Have you ever thought about going to your doctor? Something like that. All you can do is strongly encourage. We can't control anybody and make anybody get better, but we can at least offer that compassion and that opportunity. And if you guys want to call, you can talk to me and I can coach you on that too, like the specifics of words to say that might open up where it's a compassionate way and it's not a directive from a boss to an employee. And then a final question. Okay, so the benefit is up to 6 sessions. EAP is short-term counseling and assessment, so it kind of depends on how long-term the issue is, but basically 6 sessions, and then someone can continue. And usually if you think it's something for longer, what we'll try to do is find out what their insurance is and try to connect them with their insurance provider, like a counselor that's on our EAP panel as well as on their insurance panel, and connect them. Or if it's they need a sliding scale fee or something like that, then we'll do that too. So those were the written questions. Does anybody have any other questions? Oh, wait. I have 2 more. Oh, no, that's it. Oh, are the services available for the employees? Family members, yes. They're available for children in the home up to age 21, or children up to age 21, and then in school, I believe it's up to age 26. If your child is over 18, though, they need to call in themselves. And then spouses and domestic partners. But if you have somebody living in your house, you can just call us and we can see if it's an interesting relationship that I didn't mention. Just call us and we'll definitely, we can always get you connected, that person connected, if we can't do it. So I think that's it. If you guys do think of a question, you can call. And if you are a manager and you need a consult, we have EAP specialists that do that. You can also call me, Heather Graham, and I'll see what we can do to help you.
Okay, thank you so much.
Okay, thank you, everyone.
Yes, thank you very much, Heather. Very informative.
Bye.